I'm a mental health nurse, and I also have quite a lot of background in supporting people with various addiction problems, which can range to, well, just about anything really, potentially including Nicholas Luhmann and other behavioural addictions. So I'll just introduce myself. I'm based in Cardiff University in Wales, which is one of the 4 countries of the United Kingdom. And my paper is called Crisis in Recovery from Addiction Problems, the Impact of COVID-19 at the Social and Individual Level. So just go on to the next slide. So I'm going to start off by stating the obvious and presenting a few statistics. Just want to establish that problems of addiction have a devastating impact upon individuals, families, society, and the economy. And so in that sense can really be considered to be a social pathology as well as a mental health pathology in its own right. And I think one of the focuses of this conference is upon crises in society. And I want to sort of point out that addiction problems in many countries of the world are an ongoing and major health crisis. So in that sense, a chronic health crisis. So I'll just hit you with a few statistics. Substance misuse, and these are UK statistics. Substance misuse causes an estimated 9 to 17 years in premature mortality in the United Kingdom. Some statistics from 2015 to 2016, there were 1.1 million alcohol-related admissions to hospital. And that's to say nothing of the physical health problems which are indirectly caused by alcoholism. So there's a health impact and a social impact, and also a major forensic or criminal related impact of addiction problems. And the UK Crime and Drug Policy Group estimates an annual total cost of £13.9 billion related to Class A drug-related crime. Harmful consequences include deterioration of physical and mental health, loss of household earnings, heightened risk of bloodborne illnesses through sharing of needles, and criminal or antisocial behaviour. So just focusing on Wales in particular, the country that I'm currently living in, and it's true to say that there's something of a correlation between social deprivation and problems of addiction, particularly in the areas of substance misuse and alcoholism. So the further you get from London, very simply, in the United Kingdom, generally the greater the level of social deprivation. And Wales is unfortunately no exception to this. Historically, quite a deprived country within the United Kingdom. And lo and behold, it has quite a substantial problem with substance misuse and alcoholism. And it actually has one of the highest mortality rates related to drug misuse in the United Kingdom. Now, you may notice that I'm using the term addiction as a generic concept to describe many complaints, including alcoholism, substance misuse, behavioral addictions such as gambling, sex addiction, eating disorders, and the list goes on, and in fact is added to all the time. Just about anything can be an addiction. And so the question might be, can a single term such as addiction or dependency be used to embrace such a wide diversity of issues and problems? Well, the DSM-5, the Diagnostic Statistical Manual of Mental Health Issues, does have a unified definition of addiction as a complex condition or brain disease manifesting compulsive and harmful behavior. So there's a unified definition of addiction there in an authoritative manual. But I sort of want to point out that there are, I think, in many commentators would say, underlying psychopathological commonalities involved with addiction, including problems of low self-esteem, poor coping skills in particular, and that's the view of relapse prevention perspective which originated with Alan Marlatt. Unskilled emotional regulation or dysfunctional regulation of emotions, particularly issues with anxiety, and other issues such as dissonance towards personal identity and dissociative disorders. And it's interesting to note that you do get the phenomenon of migration from one addiction to another addiction with people who come into treatment. So, for example, somebody might come into treatment with a problem with heroin addiction, and that addiction may be resolved. But if, I would argue, these underlying issues are not properly addressed, they can actually start to manifest with an alternative addiction, such as alcoholism or sex addiction. And so, based on that phenomenon, I would argue that there are underlying issues, psychological issues, at the conscious or unconscious level, which are drivers for addiction problems. Add to that third sector organisations or the charities in the United Kingdom, which really do most of the work in supporting and providing treatment for addiction problems, they tend to focus on all addictions. And 12-step recovery groups, such as Alcoholics Anonymous and all the other groups which are based on that and using the 12-step format, they in totality are there to provide treatment for all addiction problems, and the 12-step approach is used for all addiction problems in the various groups which have been created to address these issues. I think that the perspective afforded by the use of a singular generic term, addiction, also facilitates easier sociological and systems analysis, which is what I'll proceed to do and present on my paper in this talk. Now, as well as this chronic and ongoing health crisis, mental health crisis with addiction issues, everybody knows that there's been a severe, substantial, acute health crisis internationally in the form of the COVID-19 pandemic. I wanted to distinguish between the direct impact of COVID-19 and the secondary impact on mortality and morbidity. So there's the direct impact of the pathogen. And as well as that, we're aware of the problem of excess deaths and secondary deaths. And this can occur in the physical health realm. So, for example, it might occur because somebody doesn't access treatment for cancer in so timely a fashion, or because that treatment is diminished. Perhaps chemotherapy was not opted for because of risks associated to COVID. And so that might be one explanation for some of the excess deaths. But a growing body of evidence suggests that the COVID-19 pandemic has led to a significant increase in mental health problems, which contributes to a substantial part of the excess death phenomenon. And of course, the interesting thing to note is that even as we may see an alleviation, hopefully, of the COVID-19 pandemic, at least in developed countries of the world, the secondary effect in mental health and addiction areas, that legacy continues. The secondary effect endures beyond the span of the major impact of COVID-19. Now, the knowledge base for this secondary mental health impact is not particularly well developed. However, emerging evidence indicates a substantial impact of the pandemic upon people with addiction problems as a specific subset of the wider mental health impact of COVID-19. Now, what are the reasons for this? Well, effective treatment for addiction problems typically involves psychosocial support in the form of individual therapy or face-to-face groups. So much of this therapy was conducted on a face-to-face basis. And this was made more difficult or impossible, certainly at the early stages of the COVID-19 pandemic. So a number of people were cut off from treatment that they needed to maintain in order to maintain their recovery. Other COVID-related factors exacerbating this are increased levels of anxiety, and many commentators believe that issues of anxiety underlie issues of addiction, social isolation, problems of unemployment. For alcoholics, the fact that they may have had to keep hand sanitizers in their house for which there's anecdotal evidence that this was a factor for relapse, and the psychological impact of quarantine. So the mental health crisis, a subset of which is addiction problems, has been called a parallel epidemic alongside COVID-19, and a crisis both at the level of society and the level of the individual. And the knowledge base and investigation of this is not well developed. Now, why am I saying that the knowledge base is not well developed? Well, I want to introduce you to a notion about mental health care in general. And mental health care has been dubbed the Cinderella service of medicine from the early 20th century. What do I mean by this? And it's often referred to as that today. Well, we know the story, the fairy tale of Cinderella, which involves a young girl who is neglected, has to do all the menial tasks, and is very mistreated by her associates. And of course, the story is a real rags to riches story, because of course she turns out to have so much potential. She turns out to be the most talented individual available, and marries the prince with the aid of a glass slipper. And in many ways, mental health care, mental health services are a bit like this. They are an area which is often neglected. It's an area which doesn't receive as much funding or as much research focus. It's perhaps not the sort of area that would be our first choice to work in, particularly when we're dealing with serious mental illness. Yet at the same time, the area of mental health has, in some senses, the greatest potential to impact upon our quality of life and well-being. Everything that we do has to be mediated through our psychological state. And very often we find many of our problems, physical health problems, can in some way be found to be some kind of mental health root of one form or another. And so in that sense, mental health care is a bit like Cinderella. It's neglected, but it could potentially be the greatest endeavor in social and health care and support. Now, my notion, this is a new notion, is that the area of addictions could be seen as a kind of Cinderella service within the Cinderella service of mental health care. And this is because problems of addiction do not sit easily within the whole panoply of what is understood to be mental illness. And problems of addiction have only really been covered adequately in the most recent versions of diagnostic manuals. And things are still lagging, certainly in terms of UK law. And whilst the latest manuals define addiction in and of itself as a mental health disorder, legislation such as the Mental Health Act Amendment 2007 does not define a problem of dependency as a mental illness, since dependence on alcohol or drugs is not considered to be a disorder or disability of the mind. And traditionally, people in practice, I can say, have a lot of difficulties in accepting problems of addiction and substance misuse as real mental health or psychiatric issues in the same sense as schizophrenia or bipolar disorder or clinical depression. And consequently, one of the consequences of this, certainly in the UK, is that a lot of addiction care and support is not actually within the mental health field. It's actually focused upon in the area of social work and in the area of forensic work. And a lot of people in prisons, I would argue, are actually petty criminals with addiction problems, or at least that's where they started. And they may not have good access to mental health care. So I want to bring a little bit of social theory into my analysis here, and I'm going to focus briefly on theories of crisis in social and political theory. And I think we have to go back to Marx for a grounding of an understanding of crisis, and then going to apply this to an understanding of what's been occurring in mental health services and the life of the individual recovering from a problem of addiction. Well, we all know that in Marxist theory, there's a real focus on the crisis tendencies of a capitalist economy based on many things, including a tenuous link between supply and demand, overproduction, unemployment, boom and bust cycles, and this can be exacerbated by monopolization. So famously in the Communist Manifesto, it's stated that the capitalist economy has this within it the seeds of its own destruction, and these are manifest in the form of its fundamental crisis tendencies. But moving on to Habermas, he developed more sophisticated notions of crises based on the realization that in the system there was a functional adaptation in order to tackle these these initial crisis tendencies identified by Marx. And so there is provision of welfare, party political representation, and the state itself will manage the economy to offset economic crises. However, particularly in legitimation crisis, Habermas argued that really these crisis tendencies have not been abolished in any way, but merely displaced to another point in the system. So we have things like a rationality crisis, where there's a breakdown of the very understanding of economics, which is used by the state to manage the economy, or a legitimation crisis, where it's realized that democratic representation can only go so far because this would be too costly and precipitate economic crisis or fiscal crisis. And so there is a limit or an undermining of the credibility or legitimacy of the political party. But the key idea I want to hold onto here is the notion from Habermas that a crisis tendency can be communicated or from one point in the system and to another point in the system, that it can migrate from one point to another. You take a Luhmannian perspective on that and the idea of interaction or irritation between different systems. I would say that enables a perspective to be there, that a crisis tendency at one point in the social system can be migrated to another point in the social system. And that, I would argue, is why we have seen this phenomenon of parallel epidemics, particularly in the form of the parallel epidemics in mental health care and addiction support. This is a crisis which has been communicated or transmitted from one point in the social system in the form of the COVID-19 pandemic to another point in the system, in fact, exacerbating or making more acute an already existing chronic mental health care crisis and social pathology. And there are other parallel epidemics which have been identified, such as the infodemic of misinformation, which occurred concurrent with the COVID-19 pandemic, particularly focusing on anti-vaccination information and disinformation. So where does this leave the individual in recovery, living through the pandemic and coming out of the pandemic? Well, another key idea from Luhmann is that we can actually treat individuals as systems in their own right. And this is a perspective which I've built upon in previous work and applied to the person with a mental health disorder living in a form of recovery. So I developed the notion of a recovery trajectory, which describes, I've defined it here, the diverse number of pathways involving varying degrees of care continuity, which persons with mental illness may take as they progress in their recovery, based on Anselm Strauss' concept of illness trajectory. And also building on the notion of recovery capital in turn based on the notion of social capital. My conceptualization is that in developing a recovery trajectory, the individual person who is in recovery will build a stock of recovery capital assets. So you will find, if you speak to somebody who's been in recovery for a long time, that they will say, well, I've been abstinent for so long, I've got too much to lose if I relapse, because I've got a career, I've got a wife, kids, house, or whatever else. And so that person has developed a progressive recovery trajectory in which they have built up a stock of recovery capital assets. Also in previous work, I've analysed the state of recovery as being one of autopoietic recovery, building on the work of Luhmann's reference to Maturana and Varela, and the idea that recovering addicts who are person-centred and empowered in their care can be seen as individual autonomous subunits mapping out a recovery trajectory along which they build up an increasing stock of recovery capital assets. Now, of course, the notion of a person in automatic recovery implies a self-sufficiency and self-maintenance, rather like a living organism. But that does not mean complete isolation or independence of that entity from its environment. A living entity will not survive in a hostile environment. And I would argue that very much what's occurred during the COVID-19 pandemic is that people in recovery with addiction problems, maintaining their own recovery, have found themselves increasingly isolated from society and from service support. And so an upwards recovery trajectory has been difficult to maintain in the context of the pandemic. And so the crisis that has occurred at higher levels of society has impacted on many people with addiction problems, leading to a crisis in their own recovery or relapse. So systems analysis in this way illuminates the way in which a crisis within society and the mental health system may give rise to a breakdown or crisis within individual service users' recovery trajectories. And the autopoietic recovery trajectory of the individual building their recovery capital is disrupted. And emerging evidence has indicated a higher relapse rate and issues and problems with recovery. But I don't want to paint an entirely negative picture about what has occurred in the wake of the pandemic, because also drawing upon perspectives of social theory, systemic and social crises are often viewed by commentators such as Gramsci and Habermas as new opportunities for systemic functionality. And in particular, there's the notion of the paradigm from Thomas Kuhn and the idea of a paradigm shift, which can occur when a social system enters into a form of crisis. And so what I want to argue this morning is that is what has occurred or could occur for many people in recovery who have hit a point of crisis in their recovery in the context of the pandemic, or in fact in the context of any crisis that might occur in their pathway or recovery trajectory. They can shift to a new recovery paradigm. And in my previous work, I've certainly drawn on ideas that recovery is a form of paradigm, and that every individual or group has their own version of recovery. So certainly from the life well perspective of the individual, each recovery version could be considered to be a paradigm of one form or another. And so shifting perhaps from one recovery version to another, a recovery trajectory that is failing and in crisis can be seen as a form of paradigm shift, especially if we understand the individual as a form of subsystem within society. Now, just drawing to a close now, it's worth noting that the concept of recovery in mental health very much has its roots in the field of addiction care and support, and particularly is a term used in 12-step fellowships and related literature. And these kinds of groups, which have pioneered the notion of recovery, are secular, some of them are spiritual, even religious, and they involve this, they have as a key cornerstone, in step one of the 12-step approach, there's the notion of hitting a point of powerlessness, which can often be the rock bottom of relapse. And that point of crisis for the individual is foundational for moving into recovery, or as I would put it, an upwards recovery trajectory. And White and Witters have described it as recovery and addiction is a fundamental focus upon an awakening involving transcendence of the self and a reconstruction of personal identity, values, and interpersonal relationships. And that, I would argue, at an individual level, is a form of paradigm shift. So a crisis precipitates a paradigm shift which can be seen as the action of transferring from an outmoded recovery pathway to a new progressive recovery trajectory, precipitated at the social level, in this case in particular by the pandemic. So in many ways, and I'm not saying that this has necessarily happened, but this is what could happen if the right kind of support is provided and the right kind of understanding of what has occurred during the pandemic can be brought about and implemented in services. In some senses, the crisis in recovery, which has been engendered by the crisis of the COVID-19 pandemic, is actually a time of opportunity for understanding how recovery can actually work, because we're dealing with a paradoxical situation where a crisis is actually the key to recovery. So in many ways, my talk is a message of hope. And it's worth noting that hope is a key component of many models of recovery. The notion of a paradigm shift at the individual level is also a new or perhaps alternative theory of powerlessness in recovery addiction. And it's worth noting that the very successful understandings of powerlessness and crisis in recovery and addiction does to an extent contradict with notions of recovery which are based on empowerment or CBT approaches, which are really about empowering the individual and giving them new tools and skill sets to tackle addiction. So how do we resolve this contradiction? Well, of course, you could take a sort of theistic perspective, which is that by letting go of one's own attempts to overcome addiction, you give way to a higher power, which is actually there in some shape or form, and that power is sufficient to overcome the problems of addiction. So I have an image there of, it's not me, but it's rather like me dressing my child who's aged 4. She tries to help me to do that, and she needs to learn to do that, to dress herself, but actually it makes it more difficult. It actually gets in the way of me actually exerting my higher power in helping her to get dressed. So I often have to say, just stay still, do nothing, and I'll help you to get dressed. It's not a perfect analogy, because of course to an extent I should be allowing her to do things for herself. But I think you can see how sometimes exerting one's own efforts can actually get in the way of a higher power. And that doesn't have to be a divine entity. It could be the higher power of the therapist, the group, or a theory of psychotherapy for recovery. Fossum and Mason have also put forward a control and release theory of powerlessness, and they posit that the person in addiction goes through a cycle of control, trying to control and resist the urges to act out, but this inevitably leads to a point where they feel they have a need and are entitled to release, and so they go into a place of release. And so the only way to arrest this cycle is actually by embracing powerlessness and letting go of control. I want to suggest that the notion of paradigm shift applied to the individual is a new understanding of how a recovery based on powerlessness can actually work, because it's only through actually reaching a point of crisis that you can move from one paradigm to another. And that's then in that new recovery pathway, you can develop empowerment and skill sets and tools, but always remembering that you had to hit that point of crisis in the first place. As well as at the individual level, at the service level, there has been a paradigm shift, I would argue, and that we're entering a brave new world of post-COVID services. There's been a massive increase in the use of teletherapeutic approaches, particularly by online technologies during the pandemic. And this change seems to be continuing as we move forwards, hopefully beyond the pandemic in developed countries. And there have been advantages of these new approaches, including easier geographical access, improved retention and accessibility, and a less confrontational context, which is very helpful for people with anxiety issues. course, there are disadvantages, such as particularly the impediments to important therapeutic elements such as non-verbal communication, touch and presence, and problems with follow-up and technical challenges, and also the possibility of digital exclusion. So finally, on the basis of this conceptual research or presentation, I propose new research to explore and understand the burgeoning post-COVID service landscape and to support the individual who's hit a point of recovery and now may be moving into a new paradigm and recovery trajectory. This would be a revisitation of work which has previously been done in the United Kingdom, which is called IAPS, Improving Access to Psychological Therapists, where there was the key idea, particularly pioneered by Professor Lord Richard Laird and David Clark, that the real thing we needed to do in society was improve core access to therapeutic services, which would enable better mental health and help Cinderella to become the princess. There was a mixed response to this approach, and many therapists wanted to keep face-to-face approaches because there was a real reliance on online technologies. Well, I think that because of COVID, we've really had to go back to IAPT again. And it's time, I think, for a reboot of the research and investigation of IAPT. Also, the massive social change which has occurred in the wake of the pandemic is fertile ground for investigation of new social and health-related phenomena, whether seen as threats or opportunities involved in the paradigm shift in service provision or the individual's recovery trajectory. This would support, if this research and understanding is developed, a restructuring and re-strategizing of services which would be more robust in tolerating disruptive factors for recovery trajectories. It's important to note that COVID-19 is not the only crisis which is potentially going to face services and individuals. And there could be another pandemic, there could be another macro issue of one form or another. Or there are always going to be crises which individuals face on an individual level. So there's an opportunity to investigate what types and forms of recovery are resilient in the face of crises which may loom. This research would also deepen the overall understanding of recovery and addiction treatment and mental health, with the possibility of generalization towards new insights into mental health and recovery as a whole. And would also, as all research in this area would hopefully raise the profile of mental health and addiction as a subcategory of mental health, and to some extent tackle the Cinderella problem. Thank you.